Hi, Adam.
Hi,
It's
Simon.
good.
Thanks very much for
It's
having me along.
it's great to have you here. It's great to have you here. Now, you're one of the experts, and I've got lots of questions. So we get lots of questions coming through on our helpline, and this video is a series of videos that we're creating just to help me understand, as well as hopefully everybody else, all of the things that are related to serious allergies and how we can kind of help people understand a little bit more, give them that a little bit more of an armory or kit it out with a bit more information. And today we're going to talk about immunotherapy. But first of all, Adam, can I ask what do you do for a living? What are you? What you do? Where do you come from?
I asked that question myself many mornings.
Don't we
So,
all?
quite. I'm a professor of pediatric allergy. So my day job as such is at Guy's and St Thomas's Hospital. Now we have to say it's the Evelina London Children's Hospital. So that's essentially the very large pediatric arm of Guy's and St Thomas's Hospital. I've been there as a consultant pediatric allergist since 2006. So remarkably 16 years, having trained originally from London, having trained in North London as a paediatric allergist over the course of 5 or 6 years. Um, I am also involved in sort of other areas. Previously used to be director of something called the Allergy Academy, which was a allergy education program that's still running under the leadership of Dr. Tom Mars, and was recently the president of the British Society for Allergy and Clinical Immunology, which is our specialist professional group between 2018 and 2021. Just recently, having stepped down from that, I've taken on the role of chair of something called the National Allergy Strategy Group. So that's the essentially the lobbying arm of all the different stakeholder organisations. So yourselves, Anaphylaxis UK, Allergy UK, and BSACI, the British Society, working together to lobby government and other agencies for better provision of allergy services.
Indeed. And with all of that, it's an extremely busy day for you. So it's super grateful for you giving up your time here today. So what sort of ages then would you see then, Adam?
So this is a bit of a debate in lots of different places as to what constitutes pediatrics. So
Hmm.
in lots of parts of the world, an allergist just sees everybody from cradle to grave, so from birth till old age. Some places like the US, the UK, Australia, we train a little bit differently, and we train either as pediatric allergists or adult allergists. And what that means in practice is that we train as general pediatricians initially, and then you do additional years of specialist training as a pediatric allergist. But that means I see anybody from zero, and at our hospital, our cutoff is 16. That said, there's other hospitals where pediatrics goes up to 18, and other places where they essentially say until the end of full-time education. So there's
Right.
hospitals across the country where pediatricians will be seeing people 19, 20. I generally say
Right.
to my patients, if you're taller than me, then you should probably be in adult services, and that usually holds.
Right.
But in reality, if you come into any pediatric allergy clinic, there are way more children under the age of 2 and 3 than there are 14 and 15-year-olds.
Right. Right. Crikey. Normally the kids are about 12 when they get taller than me. So I've been pretty used to that. And what's your catchment area? Is it just London?
So no, as a specialist service, we do see people from pretty much far and wide, and depending on complexity, people will come further. So Guy's and St Thomas's essentially acts as a secondary care, so like a district general to our corner of southeast London, which is still a very large catchment area, but we're a specialist centre that will go as far as it needs to go. So we do get people coming from all over the place and even overseas.
So still referral from the GP being the first port to call, and then get a referral on.
Yeah, and frustratingly, in the olden days, it's sort of up to pre-pandemic, you could get your GP anywhere in the country to refer to our service at Guy's and St Thomas's, which was something we were really positive about because it meant that
Mm.
people could really access us. Unfortunately, things have changed a little bit, and the hospitals restricted that, and so GP referrals have to come from the local area, which
Right.
means that if you want to come and see us and you don't live within our catchment area, then you'll have to be referred on by a paediatrician, so somebody in secondary care, so district general doctor or another specialty doctor from another teaching hospital in order to get to us.
That's great to know. So, I mean, immunotherapy. There's a lot of talk around immunotherapy. There's lots of new things coming out, new medicines. But I mean, what exactly is it? Is it a cure?
It's a great question, and it's a fundamental question. And I think one of the things that people don't realize is that it's really nothing new. People were doing immunotherapy over 100 years ago. So the idea is you retrain your immune system to be less sensitive to something by exposing it on a regular basis. And the origins of immunotherapy are in desensitization, which is the other word for it, to things like pollen. So for people with bad hay fever. So there was a discovery in 100 years or so ago that if you gave somebody injections or shots of pollen over a period of time, their hay fever would gradually get better. Now, that over time had its ups and downs. There were times in the 50s, 60s, and 70s where loads of people in the UK were going to their GP and getting their allergy shots for their hay fever and benefiting enormously, apart from a small number of people who would have horrible and actually more than life-threatening, actually fatal side effects from having these injections. So as a consequence, going to your GP and getting your allergy shots disappeared in the UK, even though it's still something that happens in a very almost industrial scale in the US. It's still a very popular treatment over there, done a lot more safely than we were able to do it a few years ago. So I think we learned valuable lessons. Number one, that it works, and this idea of vaccinating our immune system, exposing it deliberately to the thing that's the problem in the right amounts, can actually reduce the response that you get to it. But also, it was a very clear message that this is something not to be messed with, that you have to do it incredibly carefully. And then over the last 20 years or so, there's been a way more interest in the idea of doing this to food. So the idea that, well, wait a minute, if it works for your severe pollen allergy, why wouldn't it work for your peanut allergy or your tree nut allergy or your sesame allergy? And in fact, the early days of this in the 1980s, there were some studies that used a very similar approach to the way that pollen desensitization was done with injections of peanut protein, and these did not end well. They led to very severe reactions, and the thinking at the time was, okay, this isn't going to happen. But then big changes happened around the way that people were desensitized to pollens. Instead of getting injections, they started getting what's called sublingual immunotherapy. So that's where it just goes under your tongue, a tablet with an enormous dose of grass pollen or tree pollen or house dust mites. And that showed pretty much the same effectiveness, but dramatically safer. And in all the years of sublingual immunotherapy, it's estimated that probably more than 2 billion doses of sublingual immunotherapy to pollens and dust mite have been given, not a single death. This is a safe treatment and also very effective, which is great, but frustratingly something that is very difficult to access in the UK compared to other parts of Europe, where it's way more widely available and used very effectively. But then over the last 20 years, this food immunotherapy story has really taken off, because this idea that you didn't have to inject somebody, you can actually get the allergen in a different route, got a lot of interest. And so people started to experiment with things like peanut desensitization by giving tiny amounts of peanut and gradually increasing the amount slowly over time as a way of reducing sensitivity. And just to go back to your initial question, this is a really fundamental point. It's not a cure. If you are desensitized, essentially what's happening is that the treatment is causing a temporary state of you being less sensitive, so that it needs
your tolerance, in effect, is built
exactly,
up
it increases your tolerance. Now, I have to be careful, because tolerance in the allergy world means you're not allergic. So we will always avoid using that term when we talk about desensitization deliberately, and we talk about sustained unresponsiveness. We like a fancy term. It wants to sound cleverer. Essentially saying that you can induce this state where you're just less sensitive. Now, the value of that is, for example, with peanut desensitization, usually most of the programs that we do aim to achieve a point where a child who often would react to 20, 50, 100 milligrams of peanut protein, you get them to the point, slowly increasing the doses, so that they can have about 300 milligrams of peanut protein. That's equivalent of one really big peanut or 1.5 normal peanuts. They can eat that much reliably without having any sort of reaction. And the benefit of that...
Is this something that a parent would do at home, or would it be under a supervised conditions?
So it's a mix of both. You know, the golden rule in immunotherapy and desensitization is that you don't increase the dose yourself at home. So that's usually done under medical supervision. And if you're okay under medical supervision, you'll then be told to go home and give the same dose at home every day for 2 weeks, 4 weeks, however long, until you then come back because you've been fine with it, and we'll try and give you a slightly bigger dose. And then if you're okay with that, you go home and have that. So you go through this sort of step by step going up. Right. And once you get to that level of, with peanuts, for about 300 milligrams, we know that if you're okay with 300 milligrams and won't react, actually the vast majority of accidental reactions that happen out in the community are to less than 300 milligrams of exposure. So what generally happens is it's not often that somebody says, oh, I accidentally ate a peanut butter sandwich. It's usually I ate a biscuit and it had a small amount of peanut in. Yes. And by making yourself that much less sensitive and okay up to 300 milligrams, then you're not going to react if you have an exposure less than 300 milligrams. And that's, you know, that's of course you know, really helpful, and reduces a lot of anxiety, because people know that you have to have a really big accidental exposure, which rarely happens, in order to cause any trouble. That said, sorry, I was just going to say, there's an enormous caveat here, which is that getting to that point is not plain sailing. It's not just a matter of do it because you can and it'll work and it's great. It carries significant risk. You are putting the patient in harm's way every day, every time you give them that dose. And so there's a lot of management that has to go around that to make sure that you're reducing the risk as far as possible, because frustratingly, you can be absolutely fine when we give you 100 milligrams of peanut protein in hospital, and absolutely fine for a week at home having it every day. But then you've got a little bit of a cold brewing, suddenly that reduces your sensitivity, and boom, you react to the same dose you've been absolutely fine with. So, you know, it's a it has to be a very carefully managed process.
And is that because maybe your body's just generally more vulnerable because you might have something like a cold or another illness coming on, and your body just can't fight off that extra dose?
So we often talk about cofactors with anaphylaxis. So there are a load of different things that will influence how likely you are to have a bad reaction and how little you need to in order to cause a reaction. So it would be really nice if we could say that for any individual patient, you can define a constant of saying, okay, this patient will only react if they have more than 150 milligrams of peanut protein.
On any occasion, by age or the weight of the child.
Well, a lot of those things will potentially influence it, but those are things that are sort of relatively static. You know, if you could say reliably, you will only react if you eat more than 150 milligrams of peanut protein, you could say, then don't worry about the may contains, don't worry about a little bit, because we know that as long as you don't have this much or more, you're going to be fine. But it doesn't work like that, because those things aren't constant. And what you'll find is that children who react only to 150 milligrams on one day, on a different day when they've got a bit of a sniffle, or they didn't sleep well the night before, or they've just stepped off a long haul flight, or they've just done a little bit of exercise, we'll find that if they then have 50 milligrams, they'll have a reaction.
Right.
So it's a constantly changing thing. So although you do get some people who are broadly less sensitive or more sensitive than other people, it's not a fixed amount that causes a reaction. It varies, and that makes these sorts of processes potentially risky, because you might find that you're reacting to an amount that you thought you were okay with. There are a load of ways that you can mitigate that risk to make it much safer. And, you know, there's a reason why things like Palforzia, which is essentially a capsules of peanut protein to allow for desensitization, so desensitization program, it's got its license, because when you step back and sensibly review it, the regulators thought actually the risk is worth the benefit. But it is not without risk, and I think that's a really important point. And one of the things I always say whenever I'm talking to families about desensitization, there's a little bit of a sense of, we can do this, so we should do this. And that's absolutely not the case. Just because we can desensitize kids now doesn't mean it's right for all of them. It's not right for a lot of patients. for all sorts of reasons, sometimes for medical reasons, sometimes for logistical reasons, sometimes simply for essentially personality reasons. It's a treatment that actually creates a lot of anxiety because of this regular dosing that has to happen. So a lot of counselling has to go into that thought process as to, is this the right thing for any individual patient? And we refer to this as shared decision making. It's a whole process of providing information, having conversations over a period of time. It's not a one-off, let's have a chat for 10 minutes and decide whether you're going to do this or not. It's a process, because for most patients, actually, after you've had all those conversations, the agreed plan of the best thing to do is not to desensitize, and that's absolutely fine.
And how long does it take? Does it, I think you mentioned there about 6 weeks. Is that generally the case, that like 6 weeks worth of treatment, then you're desensitized sufficiently?
Very broadly, you can look at any desensitization program, break it down into sort of 3 sections. There's the initiation, which sometimes is giving quite a number of often very, very small doses, but in very quick succession, for example, on the same day. You might give 4 or 5 doses. Not all of the programs do that. Some of them just start with a single dose. So that's sort of treatment initiation. And that's often sort of getting an understanding of what is the existing threshold for causing a reaction. Then there's a period which is known as updosing, which is when you come in, have a slightly bigger dose, go home, have that dose at home, come back, have a little bit more. So that's the sort of in and out and in and out. And in the common programs that we do, that might last for 4 months, something like that. But obviously, if you've got lots of coughs and colds in the middle, that means you don't have the doses that day. That will lengthen the period of time. So it's a bit of a movable feast. In the US, they do protocols that take kids up to much higher doses than we tend to do in the UK, and so those will take quite a lot longer and could be months or even a year of increasing the dose regularly. But bear in mind that has that's got significant logistical impact, because that you continually having to come back and have visits in order to increase your dose. And then you get to,
presumably it's the stress that parents will need to go through every day, giving their child an increased dose.
Well, that bit doesn't even end, because when you get to the sort of your top dose, so the dose you're aspiring to get to, we refer to that as the maintenance dose. Excuse me. The maintenance. Once you're on that maintenance dose, you then go into the maintenance phase, where you just continue to take that dose on a regular basis. And this is that's the third part of it. And this is indefinite, because, again, going back to your initial question, this isn't a cure. If you stop giving your child that allergen on a regular basis, pretty much every day, as it's gone on for longer, you might be able to reduce it to 4 times a week or 3 times a week. But if you just stop, you go back to where you started. You just go back to being allergic again. No worse off, but you've lost the effect. So this is not a permanent effect. You're maintaining this temporary effect of being less sensitive, but you have to tend to it. And if you don't continue to expose regularly, then there's a risk that it will disappear.
And that's lifelong.
Well, we think so. There's no, the evidence suggests that it will remain as long as you continue to be exposed. And I think one of the more exciting things about desensitization is that it certainly appears that in younger children, particularly, if you get on and do this young, then that little regular maintenance dose is actually working on your immune system on an ongoing basis. And for example, in children between the age of 1 and 4, so there's a number of studies that have now shown this. If you can get them to sort of 300 milligrams on a regular basis, which offers them that bite protection we often refer to as protection from small exposures, but they maintain that for a year. If you then bring them in and say, right, how much peanut can we give you before you'll have a reaction? Most of those kids can tolerate 25 peanuts without a reaction at all. So actually their tolerance has got way better as a consequence of that regular exposure, which is fantastic. And being able to take that through, even though they've not outgrown their allergy, they're still allergic, but if they continue that and maintain that regular dosing, that offers very real protection to them as they go through their teenage years, when they're at particular risk of nasty reactions. Knowing that they still have to say to everyone, I'm allergic to peanut, they're still carrying their adrenaline injectors, but knowing that if they get it wrong, actually chances are they'll be absolutely fine.
And to access these sorts of medications, that it's your first step, as with a referral to your services, it's through the GP.
Yeah, I mean, exactly. This is all very much in its infancy, and if you've got a peanut allergy, you'll probably already be connected to an allergy clinic, and it's worth raising, if this is of interest, is this something that's being offered. So in This Palforzia is the first sort of licensed product for peanut desensitization between the ages of 4 and 17. Got its license in the US in, I think, December 2020. Got licensed in the UK in October 2021. And it got approved by NICE, so essentially the NHS, saying that yes, this is both effective and cost effective, in February of 2022. And then essentially that sort of gets rolled out to specialist services, say, guys, you need to start offering this to patients. Certainly at Guy's and St Thomas's, we've had our first patients, which is fantastic and an enormous testament to a fantastic team of people who have been thoroughly under the cosh because of the waiting lists as a result of the pandemic. But other specialist services are also getting up and going with this. The problem, of course, is that there's an enormous number of people who are very interested in having this, and not many specialist allergy services. And so something of a mismatch. Now, every service will have to come up with its own way of triaging who they want to put through this first. And there's, it's going to take a long time to get through the likely numbers, but thank goodness at least it's happening now.
That's very interesting. That's very interesting. Adam, thanks very much. That was fascinating. And I mean, I guess it gives a lot of hope for people for the future as well. No doubt, there are more medications and more things in the pipeline that in the future would give hope to us all, I guess, and kind of keeping kids safe is an absolute priority, and making sure everybody's safe, and these
medications
are a kind of a route there, aren't they?
Yeah, I mean, this is an enormously exciting time in the field.
Yeah.
And, if I go back to when I started, we were very much about diagnosing your allergy and then crossing our fingers and saying, come back in a couple of years and let's hope it's gone away. But sadly, it seldom does. Now it couldn't be further from that. We're able to adopt a much more aggressive approach to saying, okay, there's stuff we can do about this, and that goes for respiratory allergies and things like bad hay fever and dust mite allergies, but also now food allergy as well. And this is increasingly the way the specialty is going. And if you look to the US, where I think it's fair to say that they're ahead of us on all of this, for all sorts of reasons around the structure of their healthcare system, that is where it's going, and it offers definite advantages. But then beyond that, you look to research, and there are lots of different ways of desensitizing people. So there's a lot of interest in patches that you literally stick on a patch, and
just like a plaster.
Yeah, so exactly. So the idea that can make you less sensitive and have way less side effects, that will be the real benefit there. People are doing desensitization by mouth, but alongside other medications that dampen down any potential reactions. There's a lot of interest in sublingual immunotherapy, which I mentioned earlier for pollens, but doing that for food and for nuts. So the future is looking really, really bright, and also just medicines that you can get a shot of, and it will just dampen down all of your reactions regardless. So for people who have got lots and lots of food allergies, this idea of just going through a very complex program for one of them so that they're less sensitive to that doesn't feel enormously appealing, because it doesn't help them for the 25 other foods they've got to avoid. So medications where you have a shot of this and it just dampens down everything are obviously very appealing as well. So there is loads going on. And I think that the future is very, very bright for for our patients. Unfortunately, these things take a long time. Rightly, they have to go through incredibly rigorous checks of efficacy and safety, but there's plenty happening.
Adam, Professor Adam Fox, thank you very much.
Pleasure.